going to give you the results that have been reported first time at ESMO last year and second time at GOSCO in February this year by Chris Parker. It's about the phase 3 Alsimca trial. First, some remarks. What is radium-223? It's obviously a radionuclide, all right? What does it? It acts like, and this is a nice model, I guess, it acts like calcium. It's integrated into the bone as calcium. So in osteoblastic metastasis, where you have, besides osteoclastic action, also a lot of osteoblastic action, it is incorporated into the bone. Alpha-radine, as the name already suggests, is an alpha emitter. This is different from all the radionuclides you have been known so far. Radium, samarium, strontium, name it, are all beta emitters. So where's the difference? The energy emitted by an alpha emitter is much higher, and the distance you can reach is much shorter. So the cell kill, in terms of that you can really kill tumor cells in the bone, is much more effective if you use an alpha emitter. In 2007, a phase 2 study has been published, largely unrecognized actually. I never heard of that study before, and I didn't stumble upon it. And it was actually a randomized phase 2. You see radium-223 versus placebo, 60 patients plus. And the surprising thing here was really that there was a difference in overall survival. And this was the sort of the base for going into a phase 3 design. It was a 2-to-1 randomization. What type of patients did we have? Oh, this is in German, I recognize. Very good. So we had patients pre-docetaxel, and the definition was who are not fit for getting chemotherapy, whatever that might be. It's hard to define what type of patient is that. And we had post-docetaxel patients. All the patients were symptomatic, had bone pain. And they were randomized getting radium-223 versus placebo. The trial was unblinded in the middle of last year. Due to that overall survival advantage, 2.8 months. In the meantime, we have another analysis showing over 3 months survival advantage for radium-223. Also, as you would expect, there was a significant difference in delaying the time to first SRE. That means 13.6 months versus 8.4 months. So not only an overall survival advantage, but also palliation and bone protection. Also, other secondary endpoints were positive, like time to total alkaline phosphatase progression, total alkaline phosphatase response, and time to PSA progression. Actually, there was no difference in PSA response. So this is one of the drugs, it's not a drug in that sense, where there's no real difference in PSA response. And we had other compounds in CRPC where we have the same problem, but there is a difference in overall survival at the end. If you look at subgroups, interestingly, those patients who had bisphosphonates had a larger benefit in terms of survival again than those patients who did not have bisphosphonates. The only subgroup where the forest is going through the one line is those with ECOG2 patients. And if you look at other phase 3 studies, this is very consistent. Also in the MDV study, in the abiraterone study, mostly ECOG2 patients do not benefit in terms that they'd have a longer life with these compounds. So what's the side effects? That's always the other side of the medal. And if we look at all grades AEs, remember AEs are not necessarily related to the treatment. It's just if anything that happens in the trial. You had more AEs in the placebo arm than in the radium arm. What does that mean? It does that mean this is an advanced disease population. If we look at discontinuation, again, more patients discontinued in the placebo arm than in the radium. And this gives you an overall feeling that you have a low toxicity drug or compound at hand. Now let's look at some adverse events of interest. How about hematotoxicity, like anemia, neutropenia, and so on? And again, here we have a favorable profile. You see grade 3 or 4. There's no significant difference between the groups. A little bit in the neutropenia. And also in the other, if you look at across that table, which is pretty complicated, again, bone pain was better in the radium group, diarrhea, no difference, nausea, no difference, vomiting, no difference, constipation, no difference. So overall, this is kind of a much less toxic profile than, for example, if you compare it with chemotherapy. This is the conclusion from the original authors. Significant prolongation of overall survival, time to first SRE, and well tolerated. And this is my conclusion. This is probably a very promising addition to our armamentarium to treat CRPC, even in the view that we have new hormonal therapy, because any type of combinations, even with chemotherapy, are thinkable. So we just tip at the beginning of the potential of this drug. There are trials in the work, more upstream in the course of disease, like in asymptomatic patients, like even in hormone-sensitive disease. And for practical reasons, we have EAP programs. I just talked to someone outside. There will be an EAP program in Switzerland, and it's expected to start somewhere around August. And we have the EAP program in Germany, and we're expecting it to have it started somewhere, hopefully, in April. Thank you very much.
Questions from the audience? So, Kurt, how do you think this, you alluded to this, but we obviously have abiraterone, MDV 3100 coming down the pipeline with proven survival benefit in the post-chemo space. Do you think this drug, this approach has a chance relative to those, or will it be complementary? How do you think it's going to pan out? I think
complementary is probably the best way to think about. In the Alsimca trial, all the patients were not allowed to have visceral metastasis, actually. So it's bone exclusively. But as we all know, we have there is always patients that have a high load on the bone. And why not combine it with any type of new therapy we have? We just got the information, I think that's, that Cougar 302 has been unblinded, or is being unblinded, which means we have the a development that we had expected. Hormone therapies will go pre-chemo. I mean, at least abiraterone will go pre-chemo, and we of course expect the same for MDV. And then you could speculate. Again, that's what we just did. You could speculate. You can combine it even in asymptomatic patients. We have no information. This is a six-shot treatment with 50 kilobacterial. I don't know what kilobacterial. But you repeat it. You could give 8. You could give double the dose. We have no information on that. So there's a lot of way you can really kind of, manipulate the whole thing and see what type of patients do have a benefit if you combine it with, let's say, any type of hormone therapy.
Laurie?
So that's probably the future of it.
Peter Albertson?
Yeah, similar question. Do you see this drug being used after people have bone metastases that are painful, before they have pain but have obvious lesions on a bone scan? Or do you see it before they even have that, but a high PSA around 100 when you know the bony metastasis is imminent?
Well, we have, good question. As you're aware of, for the denosumab, the ODAC has refused to have that further processed for delay of the onset of bone metastasis in high-risk patients. So I would be reluctant to predict that with this type of compounds you can prevent bone metastasis or even relevantly delay bone metastasis. But what you can do really is to use it in asymptomatic patients probably. I mean, formally, if you have an overall survival advantage, at that very point you are authorized sort of to use any drug because you don't need to palliate, you can have survival advantage. And probably even if you look at the ECOG data in poor performance patients, you have a better survival advantage. So the thinking could be in the better patients, even more upstream in the course of disease, asymptomatic patient, the survival advantage could be even better. So yes, I would predict, yes, we will use it in asymptomatic patients who have bone metastasis because we have probably a deficient cell kill there, and it might even have a better benefit for overall survival. But this is, again, I mean, everybody can speculate about the future. Huh?
Manfred?
Short question. You know, that the SREs were prevented much better with this compound than with denosumab and the bisphosphonates. Can it replace bisphosphonates and denosumab?
Yeah, well,
Because you say it's like calcium, it stabilizes also the bone. Why using both?
well, I mean, one argument could be that in that subgroup with the patient who had bisphosphonates, the survival advantage was actually better. So there could be...
But not, this was not significant.
No, it was not significant. You're right.
Was
This is
a
just a
trend
trend.
only.
So again, we have no answers for that. Yes, it could replace it, but it also could be complementary to that. So again, you know, with all these new studies, you answer one question and you got 50 new questions. And we cannot do all the studies to answer these questions. That's the problem. But yeah.
For these patients who were at the end of the road, I think the major concern is quality of life and not prolongation of their life. And so I think overall survival is not a major endpoint. What does alpha-radin translate into improvement of quality of life, say pain, in this study?
We don't have quality of life data yet. We have pain information, but that has not been published yet. But you're right. The important thing here is, like, you know, delaying SREs has been accepted as an endpoint. By the way, the only accepted endpoint by the authorities beside overall survival. But of course, you must look at other quality of life domains. Especially for me, pain reduction would be the one that is really important, because these have been symptomatic patients. I have to look at it. But as been asked, I do see that this will not be the primary indication for this type of compound in the future. It will be more on the asymptomatic side. But for the time being, you're right.
But just to emphasize that this product has virtually no side effects. It really is remarkable in terms of its profile. So for the older patient for whom chemotherapy
Correct.
may be toxic, or even the steroids that you have to give with abiraterone, it's very appealing. Okay. Thank you, Kurt. And the final speaker for this morning, back to Manfred Wirth.